So with no further ado, extremely excited to introduce to you, all of you, Jacques Marescaux, founder of IRCAD, and also the individual who has done the world's first telesurgery from New York. So this is extremely exciting to hear this story today. Professor Marescaux, thank you for being here. You're one of the, you're the, probably the best innovator, one of the best innovators in Strasbourg. IRCAD is recognized globally as a hub of excellence for surgery, for innovation. You're working with the best companies from Medtronic, Siemens, Intuitive, Karl Storz, you name it. So it's really an honor to have you today. So thanks for being there. And I will leave the floor to you. And I hope everyone is doing well in the attendees. Feel free to ask questions, network in the chats. This is also there for that. So thanks everyone for being here. Thank you.
Thank you very much, first of all, Alistair, for your kind introduction. And thank you, Alistair and Nicolas Pellerin, for organizing this kind of session, because I think it's very motivating and it's very interesting. And also, I'm very happy to meet for the first time Dara Paradiso, our General Consul of the United States, who arrived just in August. It was not a good period, but I hope she will visit IRCAD, because we have so many collaboration with United States. So my topics will be short, less than 15 minutes, to explain what we do in IRCAD, the history of IRCAD, the relation we have, and we can start by the first slide, please. Okay, so the topic today of IRCAD, the institute we have created now 27 years ago in Strasbourg, is to try to invent the future in surgery. That means a mix between robotics, imaging, artificial intelligence. I have to say that when we decided to create IRCAD, that was after an exceptional lecture of this man, an American colonel of the US Army, a surgeon. It was in 1991 in Germany, and this man has really the vision of the future. And the name of the lecture was Medicine Will Switch from Industrial Age to Information Age. And in 1991, you imagine, he explained the power of internet, the power of robotics, did not exist at this period, the power of virtual reality, augmented reality. All these concepts were only concepts. And when I came back from this lecture, we decided to create an institute totally dedicated to information age and surgery. And important to say that we have a great environment, such as University Hospital, University of Strasbourg, which is nearly in the top 100 worldwide ranking, in the ranking of Shanghai. And since the beginning, the topics were augmented surgery. And what is augmented surgery? It is augmented vision for the surgeon. That means the surgeon could see in transparency. Augmented gestural, the hand of the surgeon, that is robotics. And augmented the brain of the surgeon, and that is artificial intelligence. So augmented eye is certainly one of the most important today, because all the surgeons, they want to understand more the medical image. So that is 3D reconstruction. It is a medical image that's very difficult to understand. You have software, and with some software and algorithm, it's possible to have the 3D reconstruction of the patient. And it looks like a very realistic digital clone of the patient. We see all the details of the anatomy, and it is very easy to understand and to have the best strategy for the operation. We can do that for a lot of things. And also after that, after the reconstruction, we can simulate the operation. Here, there's these 3 little balls in green, metastasis of a cancer. With a computer, it's possible to understand what is the part we resect the liver, what is the part we ablate the tumor with heat, that is radiofrequency or cryoablation. And you see that it is possible to take this virtual image and to take virtual instruments and to know and to understand the best way to perform the operation. We take here, the virtual optic that we introduce in the abdomen, and on the left, on the window, we understand and we see the 3D image with a possibility of fusion, that means of augmented reality. And that is the next step. Virtual image, real image given by the camera, fusion of both, that is a concept of transparency, that is a concept of augmented reality. We start a lot of years ago, we published in JAMA, and you see that that is a big tumor in green of what we call the adrenal gland. So the first step is always the same. It is a 3D reconstruction. So you see that we can move the image. We have the image of 3D. We understand all the different landmarks. We understand the vessels. And during the operation, when we dissect, you see in blue, it is a big vein, the vena cava going in the heart. You see that we ask to see in transparency, and in transparency, we see the two vein, and when we dissect, you will see the renal veins, the vein coming from the kidney. You see in transparency in the fat, we see also the exact position of the artery. So that is augmented reality, and that is the future of surgery, especially if we imagine that one day surgery will be automatic as aeronautics, as automatic car. The second challenge after the image, which is certainly one of the most important, is what we call augmented hand. Augmented hand, that is robotics. So since the beginning of the creation of IRCAD, we were totally fascinated by the concept of robotics. Perhaps you remember that in 2001, we published in Nature the Lindbergh operation that was the first worldwide remote surgery, long distance remote surgery, because personally I was in New York and my patient was in Strasbourg. It was not a surgical challenge because it was very simple, what we call cholecystectomy, that is the ablation of the gallbladder, but it was really an information challenge. And you see the setting of the robot at this period, it was a Zeus robot coming from United States, Santa Barbara. It was the company Computer Motion. So that is the setting in our operating room. And you will see when everything is just installed, after that, all the work was performed from New York, and 80 engineers from France Telecom were on the bridge. And personally, I was in New York. It's very interesting because today everybody speaks about the development of remote surgery due to the 5G. But that was more than 20 years ago, and it was without the 5G. It was just ATM lines. And in New York, it was a subsidiary of France Telecom, Equant, and that was the origin of the performance of this operation. That was published in Nature. You know that it is a very prestigious paper. We work also a lot on the integration of image in the robotic system. So here you see the robot, which is the Da Vinci robot from Intuitive Surgical, also in California. And you see that the surgeon has like a GPS, like a GPS that you have in all the car. And when he is immersed in the master part of the robot, you see that he has a normal vision of given by the camera, and also the 3D vision given by the computer. And you see that it is like a GPS because he can understand all the different landmarks. Finally, we work also a lot on the concept of augmented brain. Augmented brain, that is artificial intelligence. And everybody speaks about artificial intelligence since 5 years, but we work on that since more than 10 years with different topics. One was a Condor project, which is how we can imagine to have a control tower in the operating room. And today it is possible because you see that we can collect all the data of the preoperative image, medical image, the external camera, the laparoscopic camera during the operation, all the physiological signals given by the anesthesiologist, and all that we can concentrate, we can storage, and we follow all this data until the patient can return at work. Another example of artificial intelligence is a big modification of the workflow of the patient. you know that we know that the patient has to quit the hospital very early. That is a consequence of what we call the ERAS project. ERAS is Enhanced Recovery After Surgery. We know that if the patient quits the hospital, even after a very important operation, you decrease not only the nosocomial disease, but also you decrease by 50% the percentage of complication. And we have discovered a startup who was in California, and after 2 years of discussion, this startup decided to come in Strasbourg. It is a RDS company. They have performed the best patch that we can imagine. What is a patch? It is something with a lot of vital parameters. You see that we have 11 key parameters that can go in the cloud, go in your iPhone, iPad, etc. And you see that we have an electrocardiogram, we have the saturation of oxygen, we have the respiratory rate, we have the skin temperature, you have the body position, that means the detection of fall. That is really an exceptional patch, and we know how difficult it is to put all these sensors in a very little system. And that will be a total modification of the hospitalization of a patient, because that is the only way to be sure to convince the patient that even out of the hospital, he has a perfect control. And what we work today with artificial intelligence is to imagine, you know, that if you have a big problem, for example, heart rate, immediately you have an alarm. If you have elevation of the temperature, you have an alarm. But what we would like to have is to know what is the percentage, what is the patient who is going to have an alarm. That means to detect predictive factors by artificial intelligence to know 2 hours before the percentage of patient who is going to be re-hospitalized. And that is a very nice project. And you see that you can be connected, and in real time, with just 3 seconds of latency, we have all these parameters. So we were very proud that the company just joined the team of IRCAD and IHU in Strasbourg. I just want to finish to say that with all these different modification of surgery, we need also to have a training concept. And the training is how we can train, you know, surgery is a companionship. So here we have our experimental room with the last generation of minimal invasive surgery. We work on simulators, on pigs, on cadaver, and it is the best way for the surgeon to learn the new technology. We do the same for robotic surgery. And that was after the visit of Gary Gotthard, the CEO of Intuitive Surgical in California. It was a challenge. He asked us after his visit, is it possible to have the most important place in Europe here? And in 2 months, we have totally destroyed 800 square meters. And now we have a platform with 13 robots coming from Intuitive Surgical. So that really is for us a wonderful partner we work with. We develop also a flexible endoscopy training course, because we know that flexible endoscopy, it's very important for the education of the surgeon. And now we extend our institute because we have understood that the next generation of training will be more robotic training than conventional minimal invasive surgery. So we have the robot of Intuitive Surgical, but we have also a partnership with Medtronic since long years, more than 20 years. We have a partnership with Cambridge Medical, and we have totally rebuilt a building totally dedicated to research and education in robotic surgery. I want to finalize with the globalization of the concept. You see that we have now an IRCAD show in France. It was in 1994, in Taiwan in 2008, in Lebanon in 2019, but before we had 2 in Brazil, Sao Paulo and Rio de Janeiro, 2 big projects, one in Africa, in Rwanda, one in China, and discussion today with a big company in United States to build an IRCAD in USA. So thank you very much for your time. And if you have any question, I'm totally able to answer.
Excellent. Thank you very much, Professor Marescaux. This was a great presentation. Thank you. So I'm going to start, maybe Professor Marescaux, with a question. So, it was interesting to hear about the multi-sensor patch. So what this triggers as a sort of thinking for me is, we're seeing all these rapid tests where you can test, for, potassium, diabetes, and even COVID, and now we have all these sensors. So are we becoming more and more sort of a bionic human, right? Connected to technologies, and, what's the view, what's your perspective on this? In the next 10 years, 20 years, will we be always connected to some sort of device, or what's your thinking there?
So the good question, the patch, which has been developed by the startup and now the company RDS, has several parameters. You have seen today no biological parameters, but to show it's certainly something which is going to be also important, and we can imagine to add. Something you have to understand is that it's a big change in the philosophy of an hospital. Hospital will be the platform for the period you have to operate the patient. But just after that, I mean, really, even after a very important operation, we know that it is possible to go out of the hospital after 24 or 48 hours. And I have explained during the lecture that is the concept ERAS, which has been developed in Europe. It was more in the north of Europe. So we know that the patient has to leave. But you know also that the concept of hospitalization in Europe is not the same that in United States. In United States, it's very often common to go out of the hospital after 3 or 4 days. Why? Because it is very expensive, and majority of patients, they have to pay. In France, for example, nobody pays. So the patient is very well to stay in the hospital, even when really it doesn't need any care from a nurse. And so but the patient say, I don't want to go out of the hospital. But if you explain to the patient that if he can move out of the hospital because he will have less complication. So that is something he understands. It's not to do some economy. It is just because it is better for the patient, he will accept. And for that, we need a patch. And, it's very interesting because we discuss about that since more than 6 years with different companies, also with giant. And always it was a failure because when we see this little patch, you think it's easy to have all these parameters. No, because it is more complex than just to have just a watch. You know that if you have your watch here, for example, I can have my electrocardiogram, but I have to push. And that is impossible if it is in a post-operative period. You need to have a 24 hours recording. And as I explained also, it's a fantastic tool for artificial intelligence to try to find the predictive parameters. What is the patient who in 5 minutes, in 2 hours is going to have a complication? And this patient immediately need to go back to the hospital. And we know in the ERAS program in Europe that 10% of patients have to go back to the hospital. But 10% of the patient, it's nothing, because that means 90% of the patient can be out of the hospital. So it's a total change in the workflow of the patient.
Excellent. Well, thank you, Professor Marescaux. And indeed, in the US, we have this concept, the home hospital, where a lot more patients are going to be, being taken care of at home. So a lot of technology devices helping do this. So this is really good and great to hear the passion you have when you talk about this. So we have a few questions here. I have a couple more. So we have Alexandre Blanchot, who is an economic developer in Boston for the Denmark region. So how do you see a collaboration between US and Europe when we know that US hospitals have early access and broader access to new robotic tools for surgery compared to French hospitals? What could be a win-win collaboration?
In French, which was, they have a better access or less access to robotics and new technology? I have not understood.
So when we know that US hospitals have early access and broader access to Europe, so better access, apparently the US hospital
in Europe
access, no, apparently in the US.
In US, okay, so that's true. Why? Because the first robot, they have been initiated by United States, first of all by the US Army, and after that it was developed by Intuitive Surgical, and it was very expensive because today, for example, the robot of Intuitive, it's around $2.2 million. Okay, but now, what happened? You have a lot of competition. You have sure the Intuitive Surgical robot, but you have the Medtronic robot that is in US. You have the Transenteric robot also in US. In Europe, you have the robot of Cambridge, which is a good one. You have the robot of Medicaroin done by Germany and by Japan. So what we are going to face to a decrease of the cost and an increase of the technology. Sure, advance of Intuitive Surgical, they have 10 years of advance. But when you look at the new generation of robots, they are not so bad. And some robots, you have also the robot of Johnson & Johnson, which is Verb, and Verb will be an exceptional robot. So due to the fact, and also something you have to know, that I think nearly 100% of the operation except transplantation will be performed by robots. That is for all the different specialties. 20 years ago, at the beginning, when we start and when it was a conference of Satava, it was an exception. It was like a dream to imagine the robot. It has been so long to develop the robot. You had so many conservative surgeons attacking the robot to say it is too expensive, no benefit for the patient, because it was the first generation of robot. The generation of robot, especially due to what Luc Soler, Professor Soler is going to show, that means the integration with the image. And that is the reason why Johnson & Johnson, they have invested in visible patient, and because they have a robot and they know very well that that will be a fantastic plus for the new generation of robot. So what the comment that you had, sure, it was a case in United States, but I think that in the next 5-10 years, it will be a routine to use a robot for all the specialty.
Excellent. Well, thank you for this. So one more question here. So in terms of early detection of chronic diseases, we've heard, several people today talk about the importance of early detection. So obviously you play in your field a huge role there in improving outcomes. What are the trends you're seeing that could really drastically, help with early detection?
So you have some research that we can do in our institute, and they were initiated by Professor Soler, for example, artificial intelligence, how artificial intelligence can support the radiologist to have an early detection of an image for the CT scan, etc. But we know that there is a limit of artificial intelligence, which is able only to do one task. But you have another you have, for example, Medtronic, Olympus in Japan, but Medtronic in United States. They have a system whose name is Genius. And this system is how we can have an automatic detection of a very little polyp in the colon. That means a polyp of less than 5 millimeters that very often the gastroenterologist is unable to see. And that is fantastic. Olympus is ready, and Medtronic is going to be ready in 6 months of 1 year. You can have the diagnosis. That means you can do the difference between a polyp, which is dangerous because it can have a transformation in a cancer. We call that an adenoma. And a polyp whose name is an hyperplasia, absolutely no risk. You don't need to remove that. And what we see today is that because nobody knows if it is adenoma or hyperplasia, you remove all the polyp in the world. it's billions of dollars, because you need to remove, you need to have an analysis, that means the histology, you have a percentage of complication because you remove. So you imagine the economy due to artificial intelligence. So these are just two examples, one from IRCAD, one from our partners.
Excellent. And that's what's exciting about Nextmed, where this cluster will help with these types of innovations. So last questions from Tamin Daoudi. So did creative people such as designers, architects, artists play a role in the conception of innovative spaces such as IRCAD? And do you think that design is also a key part of medical innovation?
Sure, because, first of all, we like the design. Always, I say that for the same cost of what I call a public building, like some in university, we can do some marvelous things. And we have some discussion. I remember when we had also what we call the annex of IRCAD, which is a renovation of the Arras of Louis XV. It is a building of 1755. And the architect, Patrick Join, is an internationally renowned. He has a lot of building in Las Vegas, in New York. And we had such a good feeling together because he wanted to be a surgeon. And I remember very well, he visited IRCAD, he was trained on the robot. And after that, we have a discussion. He has done an exceptional design for that. Not for free, but for peanuts, for really nothing. And after that, we had the award. I know because the AHA had the awards of the best design restaurant in the world. It was in London, 800 candidates. And all the renovation of what we do today for the robotic new building, it's always a lot of new design, because we know that, you need to work in an exceptional environment. And that is the same for all the different IRCAD. In Africa, you have to see, it will be the best one and the huge one. It is a fantastic African design. And it's very interesting, sorry, because it is a meeting with United States, but the first project was like a mall, an American mall. And I say to the president of Rwanda, Paul Kagame, no, you need to keep the design of Africa. And our architect, which is a fantastic designer, he has done something exceptional for the environment of Africa. So my answer is absolutely. As important as science, and also because I understand more the design than the science. The science is Professor Soler.
Excellent. Well, thank you, Professor Marescaux. This is a great way to close this talk. Thank you so much for being with us.
And it was a pleasure. It was a pleasure. Thank you.